Okay, cool. Then let's get started. So please speak up with your voices or with your chats. I wanna hear from you guys in terms of what you think is going on. And if it's okay, I'll leave my camera up because I don't know. I think expressions are important.
Yes, thank you very much. No problem.
Yeah, sure.
You can start whenever you're ready.
Cool. All right. So we'll just get into it. What time is it? 8:58. Brilliant. Or at least in Chicago. Okay, so I've got some head and neck stuff. I've even got some endocrine thyroid stuff. I've got some bone, soft tissue, salivary, whatever. So we'll get through what we can. I kind of wanted to start with some bread and butter things that I think are going to be useful not only for boards, but also for your clinical practice. So this is a frozen section of a oropharyngeal mass in a patient. So what are the most common sites in the oropharynx that we are expecting to see pathology?
The kind of pathology means
Well, no, what are the sites? Like, what are the when I say oropharynx, what do I mean? What structures are in the oropharynx?
Tongue.
the tongue,
Posterior tongue.
Posterior tongue, so base of tongue, and what else?
tonsils.
Tonsils, okay, right? So we have this like Waldeyer's ring area, right, of lymphoid tissue. That's base of tongue, posterior tongue, tonsils, and then up in the nasopharynx, right, we have the adenoids. So this is going to be tonsil or base of tongue. And so what do we see?
It's a nest of tumor tissue.
Mm-hmm. All right, cool. So we have normal surface epithelium here with this these very large solid sheet-like nests of tumor tissue. So, you know, all things common things being common and, you know, uncommon things being uncommon. What is our first thought on what this is?
SCC.
Yeah, invasive or in situ, or we can't tell.
Invasive. It looks
Invasive.
Invasive, yeah, awesome. So all of these non-keratinizing squamous cell carcinomas of the base of tongue tonsil should be regarded as invasive, regardless of whether you get a tiny biopsy, a large biopsy, regardless of whether you see adjacent normal epithelium or not. All of these non-keratinizing oropharyngeal cancers are invasive, excellent. And so we do, of course, our favorite surrogate immunomarker, P16, exactly. So diffuse strong will be predictive of HPV. And I'm just going to run through these rapidly because we have so many. I think this is, what are we moving on to here? Okay, we're moving on to something completely different. I'm just going to throw stuff at you in no particular order. So next case is actually an ear lesion. As you can see, it's kind of small and kind of crushed and kind of vascular.
Paraganglioma.
Pardon?
Paraganglioma.
Paraganglioma is the most common tumor of the middle ear, right? So if you were to think that that was the first, second, and third answers, you'd probably be right. And how can we tell that what this is, right? So we have these definite nests, these kind of Zellballony nests, right? In the ear, these are really tiny, and so they will often appear crushed, right? And so you may not see that perfect, like, salt and pepper nuclei, but if you look for areas that are not crushed, you'll see that, yeah, there's some stippled chromatin. You definitely see the nest. You definitely see the richly vascular stroma. So yeah, this is a paraganglioma. And so what are our immunostains here, right? So now we know, all right, so we've got synapto, which should be positive, and we've got SDH. So tell me why I'm thinking about succinate dehydrogenase. Why do I order this?
For the syndrome, SDH deficient is carnicine.
Yeah, so we think about familial paragangliomas being related to mutations in the succinate dehydrogenase gene. And so this kind of relates to the next point, which is this is a paraganglioma, right, of the